maybe a couple more minutes for people to like log into. And then you can just do it like, yeah. So you can just do slideshow. And it should just be and it's already recording. So, yep.
All right, we'll give it a minute or two and then get started so everyone can switch over. No, so it's critical care in the beginning, so there's other people, but they're all on Zoom links. Yeah. There's all right. I'm actually going to go ahead and get started because we do have kind of a lot to go through today. So I'm talking about sleep apnea. This is Katie Gardner, one of the third-year pulmonary critical care fellows. I was working with Dr. Joffrey on this lecture, just rounding out my rotation on sleep medicine right now. So hopefully this will be helpful for everybody. So just in general, sleep disordered breathing does encompass quite a lot. Probably most commonly and most well known is obstructive sleep apnea and central sleep apnea. There's also sleep-related hypoventilation, sleep-related hypoxia, snoring, and cataphrenia. So our objectives for today, we are going to be going over definitions. We'll be talking about the epidemiology and risk factors for sleep apnea, as well as the comorbid conditions associated with them. We're going to spend a lot of time on the pathogenesis of these conditions, and also discuss the associated features and consequences. I'm not sure if that meant there was something in the chat. All right, and then we'll go over the history and physical exam, discuss the questionnaires that help with that assessment, and then just briefly talk about testing and treatment. Okay. So going into the definitions, we're going to talk about the different forms of apneas. And obstructive apnea is defined by the scoring manual as a drop in peak signal excursion by greater than or equal to 90% of the pre-event baseline. There's an example here on the right side of the thermal flow where you can see the waveform beforehand and then it does flatten out. You do also need to have a duration of greater than or equal to 90% drop in the sensor signal for a 10-second duration, despite still seeing a continued inspiratory effort in the chest and abdomen leads through that episode of absent airflow. This is opposed to a central apnea where you still have that 90% drop in the waveform, but you have an absent inspiratory effort during that entire 10-second period. So your chest and abdominal leads, which we'll get into a little bit more detailed later, do not show flow. You can also have a mixed apnea that meets the criteria for that 90% drop in the flow, but it's associated with some absence of the inspiratory effort during it, but then in the initial portion, followed by resumption of inspiratory effort in the second portion of the event, as the example on the bottom of the screen here shows. We also discuss hypopneas that you'll see in terms of the reports of sleep studies. So this does get defined as a peak signal excursion drop by greater than or equal to 30% of that pre-event baseline measured with that thermosensor or the nasal pressure device flow or some alternate hypopnea sensor, but it's also associated with that 30% drop in signal for 10 seconds. There are two different criteria, and then this is important based on the patient's insurance, whether it's a level 1A criteria or a level 1B criteria. So that measures a desaturation of greater than or equal to 3% from pre-event baseline with an arousal versus just a desaturated 4% from baseline. So you have a tendency, if you're using that 4% criteria, you may not score all of those events. Here's a side-by-side comparison of obstructive versus central hypopneas. This is what we're going to be mainly focusing on in terms of sleep disordered breathing. So that obstructive hypopnea needs to be associated with any significant snoring, which you may see in the chin leads. You'll see an increased inspiratory flattening of that nasal pressure or the PAP device flow signal if it's during a titration study. You also see paradoxical thoraco-abdominal movements during the event, but not really before that event. Okay. All right, so you have an obstructive event over on the left-hand side associated with snoring in that top lead with reduction in the signal, but you still see inspiratory record. I'm sorry, those are not labeled in the manual we had. And then on the right is more of a central apnea where you do see decrease in flow, or decrease in effort associated with that. There's also some criteria related to respiratory effort-related arousals. You'll see a sequence of breaths that don't meet criteria for either an apnea or a hypopnea, also lasting for 10 seconds. And this is characterized by an arousal that follows an increased respiratory effort or a flattening of the inspiratory portion of the nasal pressure or flow device. Also going to touch a little bit on the hypoventilation criteria. So you will need to measure this with arterial blood gases. You can see an increase in the PCO2 or the surrogate value with the thermal, I think it's transcutaneous PCO2, where you'll see a greater than 55 millimeters of mercury for over 10 minutes, or you can see a greater than 10 increase during sleep compared to a value that's over 50 for 10 minutes. So two different ways to measure that. This is probably where you're more familiar with some of these criteria. You may have heard the terms AHI or Respiratory Disturbance Index before. So this is where you can break down obstructive sleep apnea into mild, moderate, severe. And this is based on your in-lab sleep study or your home sleep testing. Your respiratory event index at the bottom, which includes the apneas and hypopneas, is reviewed over the total recording time. That it applies more to your home sleep testing. The AHI includes apneas and hypopneas based on those scoring criteria we just went over, and it's divided by the total sleep time of that study. You can include the respiratory effort-related arousals to calculate your RDI, and that again is over the total sleep time. So going over the criteria for mild OSA, you'll see an AHI of greater than 5 on your sleep study, but you also will see presence of certain symptoms. We'll discuss this in the history portion, but you'll include daytime sleepiness, a patient that describes not feeling refreshed after being asleep or non-restorative sleep, fatigue throughout the day, and insomnia. A patient often describes events where they wake up gasping or choking, or someone has something that they've snored. They may even see just interruptions in their breathing pattern rather than a complete apnea. These are associated with hypertension, patients with mood disorders, cognitive dysfunction, cardiovascular disease, atrial fibrillation, or diabetes. When you see an AHI or an RDI that's greater than 15, but less than 30, or sorry, greater than 15, up to 30 is qualified as moderate, and then greater than 30 is qualified as severe OSA. That will also get you a diagnosis irregardless of the symptoms they're experiencing. When we discuss central sleep apnea, you'll see a patient that has the presence of similar symptoms of sleepiness, difficulty with insomnia in terms of initiating or maintaining sleep. They may describe frequent awakenings. They may have non-restorative sleep. They awake short of breath, and again, also may have snoring or witness apneas. This you will see the central sleep apnea index of more than 5 events per hour of sleep. And you also need to qualify if those events are scored as central or obstructive. To be a central apnea syndrome, it's more than 50% of those events. You do not, for primary CSA, you do not see Cheyne-Stokes breathing, and there's not qualification for hypoventilation there. It also needs to be a diagnosis of exclusion that's not explained by some other medical or neurologic syndrome, or by a medication like a narcotic or some sort of substance abuse disorder. This is where we're going to define Cheyne-Stokes respirations a little bit more. So you'll see at least 3 consecutive central apneas and or a hypopnea that has that crescendo, decrescendo change in the breathing amplitude. So you'll see that nice waveform where those peaks are increasing and then decreasing and have more than 3 cycles in a row. If you see more than 5 of these events per hour with the crescendo, decrescendo pattern for over 2 hours, you may have Cheyne-Stokes respirations. There are other forms of central sleep apnea than just Cheyne-Stokes breathing. You may have it related to a medical disorder with or without those crescendo, decrescendo periods. It could be related to high altitude periodic breathing. It could be related to medication or substance induced. It could be a primary central sleep apnea, or it could be treatment emergent, where you're actually doing a titration on a patient and going up too high on the positive pressure, and that can actually cause you to see more central events. So most of the central sleep conditions are associated with heart failure, neurologic muscle weakness. Those are the more common things that we'll experience with our patients. Okay, so I'm going to move on into some of the epidemiology and risk factors, as well as discuss the comorbid conditions. So sleep apnea actually affects about only 5 to 10% of adults. We see it a lot, I think, in our division being pulmonary and also in Detroit and across the Midwest with obesity. It is more common in males. So about 15 to 30% of males that have OSA have mild, if you're just defining it by the AHI criteria. If you're including symptoms, it's reduced to about 15%. And this is in the United States only, not worldwide. In females, you see about 10 to 15% incidence of it, with just defining it by an AHI over 5 events per hour, whereas opposed to more strict criteria, you'll see it in just 5% of females. It does tend to be more common in African Americans in terms of race compared to Caucasians, but that's in patients younger than 35. And this is independent of body weight. Interestingly, there is a prevalence in Asia that's similar to the United States, despite them having lower rates of obesity, but then there is a factor of more craniofacial abnormalities in different countries. So the main risk factors for OSA, obesity is one, as we'll talk about. A BMI of over 35 does put you at increased risk of sleep apnea. There is a 10% increase in weight that's associated with a 6-fold increase in risk of OSA. Male sex in general is 2 to 3 times more common to have OSA than a female, but that risk actually levels off once females are postmenopausal. In terms of age, there is an increased risk as you become older. Prevalence does increase throughout lifespan from young adulthood up to the 6th and 7th decades. Then it really plateaus after that. And again, it's more common in patients that do have craniofacial or upper airway abnormalities. Less well-established associations or risk factors for OSA include smoking. There does seem to be, in some reports, 3 times more likely to have it and have OSA in past or never smokers. There is also just less established association with family history of another family member snoring or having a diagnosis of OSA. They do find that in patients with OSA, there's a 40% of the variance of the HI is genetically based. And then about a 2-fold increase in patients with nasal congestion may or may not have OSA. So kind of going back to the comorbid conditions that are associated with obstructive sleep apnea, a lot of patients that have hypoventilation syndrome have OSA, but sometimes that's not the reverse. You'll see a lot of patients with cardiovascular disease, whether it's heart failure, coronary artery disease, arrhythmias that have an association. End-stage renal disease is another comorbidity, multiple pulmonary conditions, asthma, COPD, pulmonary fibrosis, as well as diabetes, stroke, and then things like hypothyroidism, acromegaly, and that has to do with some of the structural abnormalities, is a comorbid condition, as well as things like Parkinson's disease, which is also at risk for REM behavioral disorders. In terms of central sleep apneas, that makes up about 5 to 10% of all the patients that have sleep breathing disorders. Central sleep apnea associated with the Cheyne-Stokes breathing pattern is mainly seen in elderly men, patients with strokes or heart failure or other forms of cardiovascular disease, and sometimes those with opioid use. There is a primary central sleep apnea that's a little bit more associated in the elderly of about 4 to 7%. So treatment, I think treatment in emergent central sleep apnea is in 10 to 15% of obstructive sleep apnea. And actually one of the managements of this is that you just continue them on their PAP therapy, and this can resolve in 2 to 3 months in up to 50 to 85% of the patients. That's come up in some of the seat questions, I know for sure. Central sleep apnea is also seen in individuals when they reach an altitude of over 4,000 meters or 13,000 feet. Again, another kind of high yield question for boards in both the feet or the meter metric. So something to watch out for. Central is also seen in 10% of patients that we would see, like pulmonary hypertension, CTAF, COPD, interstitial lung disease, especially pulmonary fibrosis, then about 20% of hypertrophic cardiomyopathy patients. Central sleep apnea that's associated with Shane-Stokes breathing does have an association with higher hospital readmissions and mortality in the heart failure patients. All right, so we're going to move on to the pathogenesis. When I was preparing for this lecture, this was something didn't really feel like we weren't as in depth with in before my experience, so I wanted to focus on that with this lecture. So normal sleep, to start with, is associated with a slowing of the metabolic rate. There is a loss of wakefulness in their drive to breathe, or sorry, loss of the wakefulness drive to trigger your breathing. And there's a decrease in ventilatory motor output to the respiratory muscles and the upper airway. So we'll be talking about how that relates to the upper airway anatomy and obstruction, and also some of the snoring and the relation to the chemoreceptors and mechanical receptor stimuli. So going through our anatomy, in our neck, the pharyngeal airway is very susceptible to collapse. It's bordered by bony structures, but it itself is mostly soft tissue or muscle and doesn't have a cartilaginous support. So we're talking about the borders of the mandible, the maxilla, your skull base, and your cervical spine. And then the inferior displacement of the hyoid bone can be worsened by increased tongue volume. So everything has to fit within those structures. Obstructive sleep apnea, as it is named, is due to the recurrent obstruction of the pharyngeal airway during your sleep. This causes the hypoxia and leads to that sleep fragmentation, causing their symptoms of unrefreshing sleep, and then leading to daytime drowsiness. This is more prominent in patients with unfavorable upper airway anatomy. They become more susceptible to this. And then you may see some sleep-related changes in their upper airway function, which is what we're going to go over in more details. So this is a common picture. You probably remember this from Netters, or maybe even drawing it out for your patients when you're talking about postnasal drip or reflux. So there's a lot going on in the back of our throat. So as I described, your oral pharyngeal airway does get impacted by your tongue volume if your tongue is pushing backwards, inferiorly displacing your hyoid bone. If you have overgrowth or enlarged tonsils or adenoid tissue, that can take up space there. And then even some of the deeper tissues, as everything kind of relaxes, it all falls back and puts pressure there and closes off that opening. So this is a little bit more of a picture demonstrating that. You can see that there's nice open airway, very patent in a non-obstruction. Someone with an enlarged tongue or unfavorable anatomy has more of an obstruction there. All right, so I'm going to focus on the structural components of this. That's mostly the craniofacial structure. We went over most of the normal anatomy and how that affects things, dealing with your soft tissue, vascular structures, and mucosal factors. We will talk about more of the neuromuscular support. So that's your ventilatory motor output, your upper airway motor activity, and then actually there's a link between your intrathoracic and extrathoracic airways and a component of caudal traction on your airway. There is a little bit of information about rostral fluid displacement that I'll go over as well. So as I described here, anything abnormal with your craniofacial structure can affect your risk factors for having an obstruction. So if you have a small jaw or a lower jaw that is pushed backwards, that's going to cause more crowding in the back of the pharyngeal airway. If you have enlarged tonsils or a large tongue, as I discussed, that will also cause more crowding Different palate abnormalities, whether it's high arched or narrow, can also cause more tendency to be obstructive, as well as nasal polyps and nasal deviation. Increased soft tissue in this area, a lot of times it's adipose. You know, most of these patients can be obese, but not always, or increased vascular volume as well can cause more displacement through transmural pressures. So this probably is hopefully a common picture for you, the Mallampati examination. This helps you kind of classify how severely obstructed someone's airway could potentially be, something that you would do on your anesthesia assessment or your pre-procedural assessments for bronchoscopy or anything else. It tells you kind of inter-user reliability for some level of quantifying this. So patients with class 3 or class 4 Mallampati score are associated with higher rates of, or higher risk of OSA. Another value that can be used to compare on physical exam is the Friedman tongue position. It's similar, it does describe how well you can see that uvula and tonsillar pillars. So it's another tool to kind of describe what you're seeing there. You can also evaluate the size of the tonsils from 1 to 4, with higher numbers meaning more tonsillar tissue in the back of the throat, where it's 4, the tonsils are actually touching each other. All right, so the upper airway motor activity. Your upper airway is responsible for both respiration, eating, and then also speaking. The two main muscles that are related to sleep apnea are the genioglossus muscle and the tensor palatini muscle. Might have been a while since you've done this portion of your anatomy. So to describe what they do, the genioglossus muscle is a pharyngeal dilator. That does help prepare for an inspiratory flow intake. It does help the tongue protrude a little bit forward. Your tensor palatini muscle, that activity always decreases somewhat with sleep onset. And when it's active, it works in opposite, it decreases your collapsibility. So when it's firing, your pharyngeal airway is less flat, if that makes sense. So those distinctions are important because during your REM sleep, when you're in your deep stage of sleep, you should have atonia. You're not moving your muscles, you're not acting out your dreams or causing any harm to yourself or others during that phase. So when you're in that state, it affects those phasic upper airway dilating muscles. It also affects your intercostal muscles. It can be important for the hypoventilation patients, but your diaphragm is unaffected. So in terms of the rostral fluid displacement, this just relates to increased vascular volume in the neck. This can promote upper airway obstruction. It just causes that surrounding tissue volume to be larger, and there's not much space in that bony box for anything to go, so it's going to push on what's most collapsible. All right. I'm going to talk a little bit about kind of a theory that helps describe the changes of your intra and extrathoracic airway. So when your lung volumes change, that caliber also changes the upper airway. So as you inspire and your lung volume increases, the luminal airway or the luminal area of your airway increases. So it's preparing for that inspiratory flow. As you expire, your airway lumen does decrease in size. Can find great pictures of that. So the other thing that happens during inspiration is that your trachea actually moves caudally and stretches downward along with the carina. So that stretches some of that connective tissue into the upper airway, and that increases the transmural pressure and increases the airway caliber, kind of opening things up. So with that stretch, you're trying to increase and improve that airflow. One of the other things that occurs with the thoracic cage dynamics is that during non-REM sleep, the ratio of your rib cage and abdominal muscle contribution increases compared to wakefulness. And then this ratio is lower during REM sleep when you lose that intercostal muscle activity. So you have less of that, I guess, exaggeration of those movements, for the best way I could describe that. All right. So this is just an example of some of that being measured. So at the top you have an EEG, then your flow loops, and then looking at the volume. So on the left is wakefulness, on the right is during sleep. So you'll see a change in that volume that's being inspired, and that changes some of your flow, and it's parallel. You'll also see during sleep that your end-tidal CO2 does increase. It can go up 4 to 5 millimeters. and it's normally tolerated in a healthy individual. Bringing us to our next topic, so you will see that increase in the arterial PCO2. The decrease in ventilation leads to this increase in 4 to 5 millimeters of mercury. And again, in a normal airway with normal lung mechanics, someone without OSA, you're able to sustain your rhythmic breathing pattern from your neuromuscular triggers, and that leads to normal gas exchange and stable sleep. If you're immediately susceptible to upper airway collapse, they may have snoring. The changes in the airway will lead to an inspiratory flow limitation, but you're still able to maintain your sleep and your breathing. If you have a highly compromised upper airway, someone with severe OSA, it will lead to complete obstruction, causing those apneas and hypopneas. All right. So there is also something called loss of load compensation. During sleep, you have an increased resistance to the flow and your upper airway narrowing. Neither of those are really perceived as well. So that leads to decrease in ventilation, leading to more rise of your PCO2. And in normal individuals, you have a mechanism of that load compensation that can restore your ventilation so you get a near normal response. You don't get such an exaggeration between those values. So this is kind of looking at that a little bit. So you see 2 breaths when you're under inspiratory flow and then non-flow limitation. So you do get that change in your subglottic pressure from those conditions. There's a study that I'd like to go over that involves palm scoring. So this is trying to further define the different phenotypes of OSA. We're going to be looking at 4 different values that they looked to try to characterize, is there alternatives to treatments than CPAP. They were finding that there's about 50% of all OSA patients who try CPAP that are either completely intolerant or unable to fully be adherent to their therapy. So they wanted to look at other phenotypes to see if there's a way to kind of evaluate other treatment forms. So the P-crit is has a high pressure that's related to the critical closing of the upper airway. There's also a arousal threshold that's the minimal increase in EMG activity to cause a nasopharyngeal pressure with those upper airway dilator muscles. Then there's an overstimulatory ventilatory control system involving loop gain, and then they look at waking up earlier prematurely to the airway triggers or airway narrowing. All right. So the actually, I want to kind of talk a little bit more about that. Sorry about that. So they looked at 90 patients, 69 with sleep apnea that were using CPAP for over 3 months, and 21 control arms. All of the sleep apnea patients had an AHI over 10 and had no other medications and were healthy. They measured these different parameters on a full in-lab PSG. They also used 2 fine Teflon-coated stainless steel wires that they inserted into the genioglossus muscle on either side of the frenulum, and then they also used an epiglottic pressure catheter through the nostril down to the back of the throat below the base of the tongue to measure these. So it's pretty invasive, and these patients underwent 3 studies like this. The first study, they actually did it without their CPAP if they were using one the night before. Then they went in for their study in the lab, and then they, that first one was to quantify their AHI. The second and third ones, they went in wearing their CPAP, and the controls wore a CPAP with a pressure of 4. During those second and third nights, they were a week apart, they decreased their CPAP settings to be able to induce upper airway obstruction. They found that in the patients with sleep apnea, they had higher P-crit levels. It was found to be positive 2 centimeters in severe patients, and that subgroup was associated with twice the loop gain threshold in trying to determine their severity. Patients without sleep apnea had a much more negative pressure. That's kind of where this graph is coming from. They found that the arousal threshold in patients with sleep apnea was more negative, so they were more easily aroused than their peers that were in the control group. There was no difference in that loop gain or the genioglossus muscle response between the 2. So this is kind of where they tried to pinpoint which of these characteristics fit together, and they described 4 different categories of disease. They had patients that had highly collapsible airways in their group 1, and group 2 is moderately collapsible based on that, on those values. That was about 36%. And then looked at the other ones that had a collapsible airway, but had more of the variables that were not anatomic traits, in the 28%. And then they also had a group 3 that didn't really have much vulnerability to airway collapse. So everything kind of fell into fairly equal groups based on their study patients. So they were hoping to use those different categories to recommend PAP therapy versus mechanical therapy versus surgical therapy. So that can be used as another guide to delineate things. What was interesting is that some of those patients with non-anatomic features of OSA were pretty similar to their control group. So in conclusion, the study really did find that OSA is very heterogeneous. A lot of it doesn't have to do with a lot of the upper airway changes that I was going over. Some of it's non-anatomic that's playing a role, and that can be in up to 56% of the patients. All right. So I'm going to switch over to central sleep apnea. As far as the pathogenesis of that, so you're usually looking at a stimuli of hypoxia. That hypoxic signal is stimulating hypopnea or increased respiratory rates. You're going to see that their arterial PCO2 is lowered below the sensitive apneic threshold, causing them to be hypopneic, causing an overshoot, which actually causes them to breathe off too much CO2, become hypocapnic, inducing central apnea, having a rise in PaCO2, and then it keeps going and over and over and over. So they're trying to restore their rhythmic respiration, but there's this overshoot that causes them to possibly have an arousal, although that does not occur in all patients. So in healthy individuals, this hypopnea elicits the short-term potentiation, a neurologic phenomenon that delays that overshoot and mitigates the magnitude of that ventilatory decline. So they're able to maintain just that slightly above eucapnic state without these events. If you have a patient with central sleep apnea that's hypoventilatory, they have their central chemoreceptors are very unresponsive to that hypercapnic stimulus. So their wakefulness stimulus to breathe is gone. They start alveolar hypoventilating, leading to more central apneas. And then that arousal restores their ventilation drive and awakes them from sleep. But then this declines again when sleep resumes. So it's a vicious cycle. This is mostly associated with patients' obesity, hypoventilation syndrome, or neuromuscular disease such as ALS, or opioid use. So some of the associated features and the consequences of untreated OSA. You can also have patients coming in complaining of morning headaches. It's generally bifrontal, it tends to be squeezing, it can be behind their eyes as well, but you won't see quite as many features like you would with a migraine, like photophobia, nausea, none of those secondary factors. They may also be primarily complaining about insomnia, more so with sleep maintenance because of those frequent arousals. I also see patients bring up nocturia, so that arousal wakes them up, they realize they have to go to the bathroom, and then they're associating that with their problem waking them up when they're just being stimulated for another reason. You may also see features that are neuropsychiatric, patients with bipolar disorder, depression, anxiety. Most of that needs to be well controlled in relation to their sleep related breathing to have that completely treated. You may also see patients that have had postoperative hypoxemia. Today, one of the patients they saw actually had complained that every time she comes out of anesthesia, there's a bunch of people pressing on her and screaming at her to wake up. So sometimes that's a trigger for them to get evaluated, and then they think more about some other symptoms. You may also have patients that are experiencing nocturnal cardiovascular events. So a lot of times we think of that first thing in the morning, patient with chest pain, early morning, having issues. You may also see patients that are having arrhythmias at night that could be related to the stress of this change in ventilatory drive. Some of the impairments that untreated sleep apnea can cause is a change in like someone's vigilance or their attentive span. It causes changes with concentration, some of their cognitive functions. A lot of patients talk about difficulties with their job or complex tasks. A lot of patients around here work on the machinery or on the assembly lines at some of the car factories, so they notice disruption in that work. It also impairs their social interactions, falling asleep during a conversation, interrupting some of their home life or relationships with their bed partners, and quality of life. They're not sleeping well, they're tired all the time, they can't sleep. So they'll mainly notice when that's being impacted for them to be seeking evaluation. There is a higher rate of job-related and motor vehicle accidents. Most patients do describe feeling drowsy when they're driving or at work, so they're more prone to injury or accidents there, or getting in trouble at work, as they'll say. Some of the other consequences of untreated sleep apnea, again, the fragmented sleep, can also see intermittent hypoxia and hypercapnia, which may have an impact on their cardiac disease or respiratory disease. You see those changes in the anatomy causing intrathoracic pressure swings that may contribute to heart failure, may contribute to blood pressure or pulmonary hypertension. You'll see increases in sympathetic nervous activity, and you'll also see metabolic dysregulation. Can cause problems with glucose control and be at risk for diabetes. All right, so kind of some brief things about history and physical exam. Your history is mainly going to consist of those symptoms of loud snoring, choking or gasping or snorting, whether it's while awake or even during the day, nodding off at their desk. Sometimes they'll have interruptions in breathing, whether it's complete apnea, a spouse or a bed partner waking them up, or just that change in breathing pattern, maybe like a Sheen-Stokes where they're seeing increases and decreases in that. They will often complain of daytime sleepiness, feeling unrefreshed when they wake up, or even masking that with caffeine use. So they don't really describe sleepiness, but state that to drink coffee throughout the day, and having that inability to remain completely awake when they need to. They often fall asleep in boring or passive or monotonous situations like a lecture maybe, when you're not actively involved. And then we've talked a lot about the airway. So on your physical exam, you do want to look at their airway, look for the mild potty or the Friedman sign, look at their tonsils. You often do measure their neck. So that can be 17 inches in males, 16 inches in females, or 40 centimeters when it's measured in centimeters. You may see nasal obstruction with polyps or deviated septums or high arch palate, or any engorgement of those pharyngeal tissues. Sometimes it's more the athletes that have a bulkier neck or anything, or someone that has a lot of volume overload that's causing that collapse of the tissues. Some questionnaires that are used to help kind of give more information about their risk for sleep apnea. So the Epworth Sleepiness Scale, this is where a patient does the questionnaire on their own. They rate things, which I'll go over on the next slide, how big their risk is of dozing off is. So from 0 of no chance to 3 high chance I'm gonna sleep every time. So they rank that for different situations. It doesn't have anything to do with the frequency of when they do these activities. So it is gauging just those passive and active times. So when they're sitting and reading, watching television, sitting inactive in a public place, sitting for a long car ride as the passenger, or if they have the opportunity to sit down in the afternoon, do they end up taking a nap? Sitting and talking to another person, or sitting quietly after a meal, or sitting stopped in traffic. So that's scored anywhere from 0 for each up to 3 for each. So that can tell you how severe their symptoms may be. The stop being questionnaire, also something probably commonly familiar with. There's 8 criteria. You're seeing if the patient has any snoring. Do they feel tired with daytime fatigue? Do they have observed apneas? Are they being treated for high blood pressure? Do they have hypertension? Is their BMI over 35, their age over 50? Their neck size, is that large? Is it over the 40 centimeters? Or are they a male? So if their numbers are between 6 and 8, they do have a high risk for having moderate to severe sleep apnea. So the stop being does talk about your pretest probability. So if they have hypersomnolence in addition to any of those 3 risk factors, snoring, apneas, or hypertension, it is much higher. They found that in this high-risk population, there was a prevalence of 64% for patients with severe or ages over 15. Oftentimes, because there's such a high pre-test probability, these patients can be suitable for a home sleep test, depending on some other factors like their insurance. So that brings us into testing. There's 4 different groups of tests available. Type 1 is what you think of your head to toe wired in-lab polysomnography. That's attended by a tech that's watching the events throughout the night and doing their recordings. There is a type 2 test, which is the same leads and wires, but it's unattended, done in the patient's home. Yeah.
So one thing they may ask you is you just a question, which of these have a higher likelihood of OSA actually symptoms amongst all those conditions. So you just have to be vulnerable.
Okay. So just in case that anyone didn't hear, for the boards, next circumference from the stopping criteria can be just the one question that might come up of that criteria. All right. So we don't commonly see that type 2 testing. Type 3 is what most of us would be familiar with as far as the home sleep testing. So it composes of 2 respiratory variables, usually an effort to breathe, so some sort of strap. I'll go through this a little bit more in a minute, to monitor the airflow from the chest to the abdomen, or airflow through nasal cannula. You also look at your oxygen saturation and then a type of cardiac variable, whether it's the heart rate itself or an EKG lead. Then there is a type 4 test, but that usually only monitors either oxygen saturation and heart rate or just airflow itself through a device like a nasal cannula. So here's a kind of a cartoon picture of someone wearing all of these monitors. So you really are wired head to toe. You have 3 different areas that are monitored by EEG leads in the frontal, central, and occipital areas, and that will help define which stage of sleep you're in when on the study. You also have the electrooculagram looking at eye movements to help define REM versus non-REM sleep and wakefulness. You have an EMG that's on the chin that can detect some snoring, and it's also on the legs looking at limb movements. You have an EKG lead. It's typically the lead 2 to monitor heart rate. You also have the airflow. You'll see the thermistor and as well as the nasal pressure transducer. Then we can also monitor the respiratory effort with a thoracic and then an abdominal belt. And sometimes that's where you'll see that paradoxical movements. So then you also would have your pulse oximeter. You'll have someone monitoring which body position the patient's in, whether it's supine, prone, side lying. And then you also have video feedback for any other sleep disturbances through there. So the home sleep test itself usually just consists of that flow channel and effort channel, a pulse ox, and then their heart rate. There are 2 different types of that, the apnea link, which has the wires to a device, and then a WatchPAT, which that is on the wrist, kind of like a watch. So then it monitors the arterial tonometry and looking for that in terms of, is that a stimulus from the event itself? So it'll actually, it'll monitor, I think it's the dilation and the vasoconstriction of the artery.
Decrease in the amplitude of the vessel, and there's some most right. Then they monitor the heart rate, the heart rate, the amplitude, and then that is enough or increase in the data. That could be either from arousal or could be from respiratory event or change in position. So there are other parameters that you can look at as well. So one of them is the pulse ox. The pulse ox will drop from 4%. Then one with an arousal will be thought to be related to a respiratory. There is no flow measure over here. There is effort channel. So they replace that with which the suggestion is there is flow associated with a drop in the respiratory. You really can differentiate between apnea and hypopnea. You could say central obstructive because they do have chest volume being measured. But again, it's a home study, so it should be done uncomplicated, typical balance, all the other things without.
So this is an example of the first version of the test, the apnea link, so your home sleep test. So it will monitor your flow at the top. You'll see snoring kind of in the second line here, and then efforts for respiratory efforts. your heart rate and your oxygen saturation. So as Dr. Docker is saying, you'll see a decrease in the flow, you'll see a decrease in the effort, and then a drop in the saturation on this event.
Our kind is very high study.
And then this is that WatchPAT, where you'll see that peripheral vasoconstriction and then a change in that sympathetic stimulation. You're either relating it to a respiratory event if there's associated hypoxia or an arousal, because you don't have that flow monitor on this one.
Based on the amplitude, they can say which part of the study is REM sleep, and that's the peak portion. Which part is awake, there is a light fluid. For WatchPAT, does the patient on beta blocker? Alpha. So we shouldn't do WatchPATs on patients who are on alpha blockers, or if they have autonomic instability, autonomic disease. Probably should be. If there would be medicine, I would probably want to avoid WatchPAT. But when you go out in the field, outside, they'll be doing a lot of portable studies, WatchPAT is one of them, and the other apnea is the other study. But that's a good. We shouldn't be doing that if autonomic nervous system. Or if they have critical vascular disease as well.
So when do you decide about doing a home sleep test versus an in-lab study? So you can consider a home sleep test if the patient's uncomplicated, so not under comorbidities, not on any alpha blockade or having any peripheral vascular disease, as we were just saying. It can be someone presenting with signs and symptoms that indicate an increased risk of moderate to severe sleep apnea. So someone with a higher stopping criteria, or someone that is snoring or having witness apneas themselves. So in a patient with a lot of comorbid conditions, it's preferable to do an in-lab study. So these are patients with cardiorespiratory disease. Anyone that you're worried about a potential respiratory muscle weakness or a neuromuscular condition, you really do want to have them in the lab. If you're also concerned if someone has awake hypoventilation or suspicion of sleep-related hypoventilation, you want to be monitoring in the lab with all those other parameters. If someone's on chronic opioids, you do also want them in the lab because it's harder to pick up central apneas and clearly on the WatchPAT and the home testing, so you can see those more clearly on the in-lab study. And they also don't want to have someone that's on oxygen or had a history of a stroke or insomnia. Those are the patients you also want to do in lab.
We have two effort channels. The gold standard is esophageal pressure recording.
Yeah. Yeah, so preferably in lab. Sometimes different insurances require a home study or 2 negative home studies before an in lab. So it really depends on what you're concerned about. And then also, not what we're talking about today, but any sort of behavior disorders, other conditions, those would be in labs too. Then just to briefly go over some treatment. So for obstructive sleep apnea, that's uncomplicated. So your patient that otherwise doesn't have all those cardiovascular issues, no significant lung disease or hypoventilation, and if they've not had any UP3 with snoring, so you can start them on AutoPAT. So oftentimes they'll have a home sleep study, it's positive, patient already knows if that's the result, you're going to be starting on AutoPAT. That machine is limited to a top of 20 centimeters of water pressure. So that is something to consider. So you can set that range for them. If someone has complicated sleep apnea, so with a lot of comorbid conditions, they may need the CPAP or the BiPAP titration. Patients are started on continuous PAP therapy, but they can be changed to BiPAP if they're unable to tolerate those high CPAP pressures or it's associated with hypoventilation. So if a patient with obstructive sleep apnea fails PAP therapy, meaning like they don't tolerate the pressures, they just can't, even with a bunch of troubleshooting or not tolerating it, or they're interested in an oral appliance. Oral appliances are fitted by an experienced dentist that actually helps with the tongue protrusion in the back of the throat. It doesn't always help with that deeper anatomy. So it can be considered for mild sleep apnea if that's the patient's preference, but it does need to be fitted by an experienced dentist, and then it can be adjusted to a certain extent. Another consideration for non-CPAP therapy would be positional therapy. So that's helpful in the patients when during their study, if their position is noted to be mostly like on their side. So if they have a supine AHI that's greater than 2, but their non-supine AHI is high, you can consider like a belt or a balance to keep them on their side lying position to eliminate some of that. Weight loss is a suggestion as well, whether it's surgical, non-surgical, or medical related. Because as we saw in the beginning, every 10% weight increase, there's a 6-fold increase of OSA. So patients can have bariatric surgery referrals if their AHI is over 40, or if it's over 35 with obesity-related comorbidity. So that can be an option as well. There are surgical managements of obstructive sleep apnea. So this one of the forms, the hypoglossal nerve stimulator, the Inspire, is actually like a pacemaker generator. It has a lead up to that glossal nerve muscle, and there's also a lead down to the diaphragm. So the patient can turn it on before they go to bed and turn it off when they wake up, and it actually stimulates the tongue to keep kind of protruding as they breathe during their sleep. That's probably the very basic explanation of that. So that can only be considered though in patients when they've had anesthesia and had a look with endoscopy to see what their airway collapse is. Is it concentric or is it just like a transverse plane? Because all that nerve is going to do is help with the tongue. So it's not going to help with that concentric collapse. I guess at that rate. Other surgeries, mostly for children, tonsillectomy is preferred for pediatric patient population. Can be considered in an adult with significant tonsillar hypertrophy. You can also consider the UP3 surgery. You can also consider mandible advancement, but that's breaking the mandibular bone, advancing it forward. A lot of people may or may not consider that, depends on the patient. And then tracheostomy. Of those options, tracheostomy is the only one that's reversible, but there's also cosmetic factors and everything too with that for patients. So the impact of CPAP in sleep apnea, because hopefully, you're treating those obstruction events, so you're having less frequent arousals, you're having improvement of their sleepiness, their quality of life. Oftentimes this can help with their anxiety, depression symptoms related to their sleep. It reduces instances of motor vehicle accidents. And then a key point too is that improves blood pressure control, but only by 1 to 2 millimeters of mercury. So not usually an ICU consult for pulmonary or sleep to help with blood pressure control in the acute setting. It can reduce your stroke risk factor later on and improve glucose tolerance and dyslipidemia and fewer cardiovascular events. There's reduced risk of recurrent atrial fibrillation in some of the observational studies. And then there is been seen no improvement in neurocognitive measures at 6 months based on a randomized control trial. And there's actually in the SAVE study, no reduction in cardiovascular events if they've had established disease. So treatment of central sleep apnea. So your first goal is always to treat the primary underlying etiology. So managing their heart failure, managing any other neuromuscular disease, multimodal with neurology. And so CPAP is still actually the first line. It's not jumping right to BiPAP. So you do want to try first continuous positive airway pressure. Second, you can consider BiPAP with ST, so you can have a backup right there. That's preferred for patients that have the hypoventilatory forms of central sleep apnea. If the patient is failing CPAP, you can consider BiPAP ST, as I just mentioned. You do want to avoid it in heart failure. Patients with reduced EF, there's a study done in 2015, SERVE-HF, that actually saw an increased mortality in those patients that were treated specifically with ASV, if their EF was less than 45%. Other things that you can treat with if they fail CPAP is supplemental oxygen if they're significantly hypoxic at night. If it's related to altitude, you can try acetazolamide. You can also consider theophylline. And then there is another transvenous phrenic nerve stimulator of the diaphragm too, to stimulate ventilation. So in summary, and we went over a lot today, went over the sleep medicine definitions of OSA and CSA on your polysomnograph, as well as like the AHI to diagnose mild, moderate, severe obstructive apneas and central sleep apneas. We went over the pathogenesis, the upper airway structure of the contribution to obstructive sleep apnea, as well as some of the neuromuscular and thoracic changes that are leading to this. There's several risk factors for sleep apnea, and then we talked about the history and physical exam, mainly your upper airway exam, and your associated symptoms of snoring, gasping, choking, waking unrefreshed, and your Epworth and Stop-Banks criteria to help evaluate and evaluate their risk of having these syndromes, and then we went over testing and treatments. Does anyone have any questions? All right, thank you.